Wonderful. Well, thank you for joining us today. Excited to be here with everyone. We have a jam-packed 30 minutes ahead, so we will begin. And thankful and grateful to have New England Baptist with us today to learn from them, learn from their experiences. As we jump in, just a few announcements. Welcome back to the collaborative members that had been participating with us throughout 2025. This is our first webinar of 26. We're excited to get this back going. And as always, welcome to our new participants. We will have some information after the webinar to the new participants in regards to additional details that we'll be able to share. As always, to our new participants and our current collaborative members, if you have interest, we are more than happy to schedule one-on-one time with you for a strategy review, which is going to be slightly different this year, being that the team program has begun. So feel free to reach out to me individually. We will set up time and happy to walk through the program, where you're at, and some suggestions from a strategy perspective as you move through the 2026 year. As a follow-up as well, we'll make sure that our Google Drive is available to everyone on this call that has many resources. Anything from the granular details of the program to past webinars and past presentations. And directed to our new participants, you may ask, why does Avant-garde host this collaborative? Well, it's been very successful, and we have hundreds of people and hospitals joining us for an educational purpose. But where this came from, 12 years ago, Derek founded the company out of Harvard Business School, really focusing on surgical optimization. But as a natural offshoot, 10 years ago, we began working in the bundled payment programs, starting with CJR, then moving on to BPCI, and finally getting to CMS TEAM. So we have had 10 years of experience working with top institutions, wonderful people like Dan and Tricia, going through these bundled payment programs. And consistently, we've been able to drive about a 13 to 15% cost structure below target for our clients. And so we have a lot of experience that we would like to share. As you can see, we've been published, specifically Derek and his work in Harvard Business Review, in JAMA, and other publications showcasing the work that we have done over the past decade. So please use us as a resource. And to the stars of the show, we're really excited to have Dr. Dan Ward from New England Baptist, who is the Chief of Arthroplasty, and Tricia Ide, who is the Executive Director of Quality and Patient Safety, also from New England Baptist. It's been great to work closely with them and to follow their progress on many initiatives, but they have already started and begun, very deeply looking into how they can be as successful in the CMS TEAM program. So excited to see what they have achieved up until this point, and learn from what they are currently doing. So without further ado, I'll go ahead and pass the baton over to Dan and Tricia, and we're excited to hear and learn from them. Thank you.
Well, welcome everyone. I'll move through this pretty quickly so we have some time for questions. This will be, I don't know, hopefully high level data, but it'll give you an idea what we did, where we're at, and hopefully where we're headed. This is specific for the team's CMS initiative. Snapshot of the Baptist, pretty busy place. Currently we run 15 to 16 all ortho ORs. And if you look at the new data from AHKS, which is our kind of governing body for hip and knee replacement, we're the second busiest joint hospital in the United States. So it's a busy place. And I think we kind of have a unique perspective because we're doing only pretty much inpatient hip and knee and spine and the occasional sports and foot and ankle. It's our total spend. We work through Medicare. It's a pretty healthy number, just where we're at. And you can look at the far right. That's what we're really concerned about, right? Your upside or downside when it comes to this new bundle and what we're really at risk for and what we have to do. So we're focusing specifically for total hip and total knee arthroplasty, right? That's part of the team's initiative for us. For our Medicare specific number, we're about $2,750. As you know, this is a 30-day episode target pricing. pretty much everything that starts from the day that you're at the hospital. So anything after that, rehab, home services, readmits, acute care, all that goes into this number. Um, we knew what our number was. This is all from Avant-garde. We don't have any other way of getting and reading the number from CMS unless they tell us where we're at. And they have been a phenomenal partner with the Baptist. We were part of their beta site almost when this thing started over 10 years ago. And we've done a couple other initiatives with them already, some bundled shares and some gain sharing with physicians, et cetera, through their data. So it's critically important. And then just looking at what our actual cost reduction could be. So we knew initially we were at risk for about 3 million. Just for and that cost was identified specifically in our outpatient, our home-based setting after a total hip and knee replacement. So we knew we had some work to do there. We finally got our number. All the hospitals have their goal number. We knew what ours was. And so once we got that number, then we're like, okay, what do we have to do to not have to pay Medicare at the end of the day a check for 3 million bucks? So between the health analytics stuff from Avant-garde, we touched on that. We knew that our largest driver was in the post-acute care utilization. That's where we figured we could probably make our biggest difference, and particularly home physical therapy services. So we focused on that again, just based on the data that we have. And this is the approach we took. So we needed to identify where our probably cost reduction could come from. We went ahead then and said, okay, we knew the top kind of 5 home services that we used. We interviewed 3 of them. So we had discussions with, the stakeholders, meaning not just the physicians, but the people who were providing the home services. Unfortunately, the providers themselves are unable to substantially reduce costs. In other words, not the surgeon as providers, but the actual folks who were doing the home-based PT. A little bit surprising that I don't know if they didn't think we could do it without them or not. I don't know. But that's what drove a lot of this. So at that point, once we figured out where we could probably attack some of the savings, there's direct literature that was supportive of where we could go. So we knew from the hip and knee replacement, specifically hips, probably definitely easier than knee, if we could help modify, eliminate, change home-based PT, our number could be quite substantial in savings. This wasn't just what we felt, right? This is published data. So we used the data to help drive what we did. We knew our initial focus would be a lot easier to do this with hip replacement rather than knee. And so that's where we started. So we went with that. We knew what the data said. This is published in literature. This isn't, a bunch of guys sitting around thinking they knew what was going on. This is all published information. A lot of people we've been doing this for many years, but I think CMS, despite some of their limitations, I think they kind of have an idea where money savings could come from, right? They have number crunchers and they know where we could be doing better. So we knew home PT. We were able to eliminate costs quite dramatically through a home self-directed rehab. So we started January 1, 2026. All patients that are done in the hospital and sent home, whether it's same day or following day, the goal was not to send them home with physical therapy, but a self-directed program. Now, obviously, there are exceptions for this, excuse me, and we're still working on what those are. We know for, just the general frailty of the patient, mobility restrictions, people that come in on walkers, whether or not their home support was appropriate. If the patient's going home and their caregiver is, significant cognitive issues or is already on a walker, they're probably going to need help at home. But as you can see the number there, we eliminated home-based PT in our hip patients, our total hip patients, by 65%. That's a big number.
I think we're
So
close to 70% this week too, Dan. So that we're increasing there as well.
so it is rapidly changing. It is a little bit, I would say, I won't say frightening, but when you first start doing this stuff, you believe the data, but you're not sure you believe the data. So thankfully, our therapists, and we'll go over how we do it, but like Tricia said, we're up to 70%. So if we continue this pace, this is 65% pace, we're just through HIP alone, you're almost at $3 million savings. This is at our institution, right? Just because of the volume that we do. It's impressive. So, and I just made these slides, what, less than a week ago, and it's already changed. So you can see how rapidly this can happen. If we had projected the expansion of the project and we got into the knee side, which I think will be a little bit more complex, but definitely doable, definitely literature-based doable for sure. The savings on our part is going to be substantial again, and could almost double what we're doing now. The Baptist is a little bit unique nationally. Hip and knee replacement, knee is about 3-to-1. The Baptist is about 1-to-1. We do slightly more knees than hips, but not the national trend where the numbers are much more skewed toward knees. So modification of our acute care was significant. And even for us reviewing some of the early patient, we called patients, got information from patients. How do you think you're doing, et cetera. I read, I don't know, almost 30 some odd patient reports. They're almost uniformly impressed with what's happening. So all good so far. So the patients were discharged with standard NEBH, which is our hospital-based program, no different than a lot of what hospitals have. They were given two different sets of instructions. You can print them, which is great. There's a digital platform that we were using. I won't say it's rudimentary, but it's pretty basic, called MedBridge. There's a lot of them that are out there. So they had two different ways to do it, digital and paper. I think you'll be surprised, and maybe not surprised, but even the patients that are 75, 80 years old, they're very skilled at navigating the internet. They're not, this isn't the group from when we first started 10 years ago. They're pretty savvy. So that's very encouraging and probably something that we can exploit even more, which we're trying to work towards now. The follow-up process I do think is critical. The patients have to know what's happening before they get to the hospital that day. Just kind of jumping it on, oh, by the way, you're going home with no therapy doesn't work. It needs to start in the physician's offices. That was actually a little bit of a problem. Initially, we had communicated with physicians and schedulers, et cetera. You need to get to the people who are actually telling the patients what's going to happen. It's usually the scheduler for the surgeon, but the surgeon has to tell them what's happening. And it's still an ongoing process with us. I think we're pretty good right now, but it's still a challenge. But that's critical. We do call everyone the very first day, right? This is an anxiety reducer. If you tell the patient, we're going to get a hold of you tomorrow, hopefully before 10 o'clock in the morning, they have questions, they get home. Now you've gone over it with them. You reviewed oh, remember we gave you those sheets? Oh, that's right. The caregiver wasn't there when they left. Now the caregiver is there, et cetera. These are all the things that will help decrease, one, the calls you will get, but two, it helps the patient hugely. So a call by physical therapy. So therapy is still quite necessary in this process, to say the least. If anything, they do more now. They have to educate the patient before they leave, and they have to call them day one, try to get them before 10, just so that it decreases the amount of anxiety these patients have. You review them, answer questions, et cetera. So the follow-up process, I do think, is quite critical. If you look kind of closely at this, and this is a little bit of a busy slide, and I'm actually going to probably jump to the next one, but on our reconciliation, when we did the whole math, we thought we were on the hook for round 3. When they gave us our new number, which literally came out, I think December 28th or something, which is just kind of ridiculous from CMS. They knew these numbers a while. We knew we were probably on the hook for about 1.8 million if we couldn't meet our target objective. And I think we figured out how to do it. This is the slide that I think is helpful for all hospitals, and this is really what you want to see. You need to know what's your home health. That's the highlighted yellow. What is your home health? What are you at risk for? This is how much money that we were spending annually per patient on 2,114 cases. It's a big number. It's 4.8 million, almost $5 million of home health. And that's how much we were spending per patient, $2,261. So if there's a way you can affect that number, which is really, that's why we targeted it, as you can see in that, where you're at, that's your biggest cost driver. So this may be different for different hospitals. kind of bet it's not. I'll bet you across the hospital board, this is where you're going to be. So somehow you got to change that kind of that mantra. Um, how we did it, we just went over that, but this is a bunch of folks doing it. You got to have the data from Avant-garde or whoever you're going to use, but they're fantastic. You got to have PT involved. They got to be on board and understand that their roles are changing, right? It's a patient education issue. It's a follow-up issue the next day. You got to have some physician leader. I've been at the Baptist for 20 years. Case management and the education of the patient's critical. They need to know when they go home, they're not going to be out there on an island, which I think is what a lot of them kind of start out thinking. And then they realize that, hey, therapy shows up maybe once or twice a week for 45 minutes. It's not like they're there every day, all day, or 2 or 3 times a day. And I think when you put it in that perspective, it helps patients understand a little bit what actually is happening. Um, your home health costs, the it's kind of low hanging fruit, I guess, and I would bet it's that way across the board. And the challenge is going to be for us moving away from the hip side and getting into the knee side. If we do it correctly, hopefully we'll probably have another one of these and go over how we did it. But right now I think we're on the right pace. So, you know, I don't know how else to say it, but unfortunately, you got to go for it. It works, and I think we have really good data to show that. This is what it looks on big graph, busy graph here. The thing we were really worried about, believe it or not, is what happened to our skilled nursing. Is this just going to be patients then defaulting into going into the skilled nursing side? Well, it didn't work. They went home or they couldn't go home anyway, so we'll just put them into rehab. That hasn't occurred. You got to keep an eye on that. You know, you can see here our people going home went up dramatically without services, and you got to work hard to make sure you're watching your skilled nursing because that is a huge cost when they go. That takes that $2,200 bill and jumps it up dramatically, um, and that's something that you've got to follow, and we follow this. Basically, Avant-garde can help you do that, which is what we do. So. Without this is stuff you've already know who's involved with teams, etc. We know we're talking specific about surgical hip and knee replacement, lower extremity. So I'll end there. Hopefully, I went through that quick enough that we will have plenty of time for questions.
This is great, Dr. Ward and Tricia. Appreciate the insights. We've got questions from the audience, so let's start there. I think this is important. Um, One question is, how are patient outcomes and independence levels with ADLs in those patients not receiving home health care therapy compared to those that do receive home health care?
Yeah, so that's part of the process, right? So we're looking at that pretty closely, right? Because your PROs definitely kind of come into play a little bit on the team's bundle. They're not as dramatic as actually reducing your cost, but they will have an impact on what you do or don't owe. Um, right now, they're holding steady. I think we've seen a little bit of a slight drop. Um, there's a lot of factors involved, but it has not been dramatic. That's the thing. Like, I mean, I honestly was a little nervous about this, but the data is pretty clear. Like, if
Mhm.
you support the patients and you do it correctly, you should be pretty good. And I think for us, it's more just patient touches. You gotta keep the anxiety level low, and that's the call the next day. But more importantly, they have to know what's happening before they come in. You tell them the same day you're going home with no PT, I think you're gonna run into problems.
Yeah. Okay. Thank you.
I would just add there too
Yeah.
that Dan's done a great job socializing this months ago. So all of last year, we talked a lot about this at all of our arthroplasty divisional meetings so that people were aware, informed, and could be part of the process with us. And that was obviously, for our surgeons, but, case management, rehab, nursing, et cetera. And I think that helped us move into this along with having the data and the analysis from Avant-garde, Danny Yagoda and team to really help us pinpoint where we had opportunity to move in this space. And I will also just mention initially, we weren't calling patients till about 5 days out. We realized that that was way too far out, kind of in the end of February, and all this month in March, we've course corrected and we're calling on post-op day one, and that has, I think, shot up, patient satisfaction with the physical therapy and rehab instruction. So that was something that we course corrected since we rolled this out too. So just as a follow up to Dan's
that's great.
information.
No, that's great. Thank you. Follow-up question to that is, were all these patients same day surgery? And then what was the inclusion criteria, out or except, just the fact that they were receiving a hip replacement?
No, sorry, Dr. Wagner, if you're able to just stop sharing your screen too, maybe.
Okay. There we go.
Perfect.
Yeah, so inclusion criteria initially was you're having your hip and you were going home. You were in, period. Yeah. And then we work backwards, right? So it's an opt-in, you're in, it's an opt-out, right? So I think if you start the other way and say, well, I think who would be best for this? Well, let's see. I think this patient would be okay. Like, you can't do that. If you do that, you're not going to get a lot of buy-in. And the reason for that is simply because you have greater than 50% of the patients who qualify and will do fine if they do go home. No one has the acuity where every single patient walks in and they're on a walker and they go home and they have somebody with cognitive deficit that they can't go home and definitely be supported. And remember, like I said in the beginning, your therapist is going in twice a week max for 45 minutes, maybe, right? So this isn't like they're going home or going to a skilled nursing facility where somebody's going to be there, 24/7. Like that's not what's happening. And I think when you put it in that perspective for patients, it's really helpful. So yeah, we send therapy home. I live by this mantra. I just had it today with a patient. You can't fight a hill tribe. If they're fighting you every way, don't bother. Send them PT and move on to the next patient. Like, you're going to have some patients, it's going to be too heavy of a lift, and then you just let it happen. We dealt with this when we first went to outpatient total hip and knee replacement. Oh my God, you can't do this, da 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 da. Well, now, 80% of my practice is outpatient total hip and knee replacement. Like, it's insane. I thought it was going to be half. And now people come in asking for it. I think what you're going to see here over the next 3 years as we move towards this, you're going to have patients come in and they're going to understand a lot of it. They just don't, home PT is on the patient, and they will default into need for physical therapy if and only if they need it. And so don't fight those patients. Somebody had 2 joints or 3 joints at our hospital. They've had all this care. It's not really worth battling that patient. Some are fine with it, but a lot of them aren't, and we just don't go there. Like, okay, fine, you send them home with PT, move on. You're going to have, at this stage of the game, it's not worth battling that.
No, that's great. Did this change by chance? And this is a question from the audience as well. Did it change your readmission rate with this patient population?
It has not.
Okay.
Yeah, we're where we were. I think what the one positive of this, I didn't mention this yet, is what did happen. So I called about 4 of the PAs that work with 4 different surgeons. One's my own, and then a couple other guys. And they said one interesting thing is they're not getting calls from the physical therapist to verify meds, which I didn't know they were doing anyway. I would have no idea they're doing that because it's not kind of what I do. But I was like, isn't that interesting? So part of billing for therapy in the home setting is they go over meds. And these patients, when they go home, talking about meds, like, they have tons of information. And we've distilled it down to try and keep it as, I would say, simple as possible. But it's eliminated that call. Now, it's not a ton of calls, but those calls are involved, right? They're long calls. They're 5, 6, 7-minute calls to your PAs. So there is a little bit of a silver lining there. You're probably getting rid of something also, which is kind of cool, actually. So just a little extra positive, I guess.
Yeah, that's great. Final question. Give us a 30-second high-level overview. If you had to wash and repeat a process like this again, is it scalable? Is it repeatable? Give us an idea of what you learned from going through this.
So I think Trisha mentioned it right off the bat. Like, the Baptist is unique, right? I think we have very close relationship with the physicians. I've been there for 20 years, and it's an academic institution that masquerades as a non-academic institution. We have a ton of research that comes out of there, and I think they were most of the folks were happy to participate because the data suggests that what we're doing is as good or better for patients. So it didn't become, oh, we're just saving a bunch of money,
Yeah.
which we are, but it actually was not affecting outcomes. And that's the critical thing. And it wasn't just, this is published research, right? I don't know, I've probably read 10 different papers on this. There were two more just updated at the academy not a week ago. So that was one thing that helped us, right? Physician involvement early. We were talking to these guys back in April, like of last year. So they had a pretty big ramp up. It's still, believe it or not, like, and Trish knows this, like it was like a Christmas present still for some of these guys. I don't know, apparently they can operate, but as most orthopedists, like we like to be spoon-fed to some degree, but once they caught on board, like, oh yeah, that's right, we talked about it. So that was number one. I think that's what I would do for sure. Two, I think just from a therapy standpoint, like the therapists are critical here. Like they're critical in the early teaching, right? They got to go with the patients, and the calls that go out to these patients need to be immediate. You can't create anxiety on post-op day 2, 3, 4. That first call is really helpful for two reasons. One, anxiety. Two, a lot of times the caregiver that's actually going to be there is actually there. They weren't there at discharge. They didn't get that information. The patient goes home with the information. They're not sure where it is, but now that person is there. So you might catch them in the hospital before you leave, and you might catch them at home again. So it's a nice little, you know, I guess, catch up. Um, I can't, I understand you guys sponsor this, and this isn't a plug. I don't, I'm not a paid consultant with Avant-garde, just so everybody on the call realize this. You have to have the data. Like if you don't have the data, you don't know where to go. Um, Obviously our data sets are huge, which is really, really helpful. Um, but we're also on the hook for a lot of stuff if we don't do it right. Um, so if you get the data and you lean on the folks that they can really help you kind of see the light. Um, Maybe you'll have better options, like I talked about right away. We brought in our three our most used services, and unfortunately they didn't have a way really to work with us. I don't think they understood the importance of it. That may be a thing I would love to almost redo. I think now they would maybe have a better idea or better helpful for us. That's where we're actually going to go with knees, right? We're going to have to cut the knees down to some degree. And I think now maybe we'll be able to proceed better as a team with some of our home health services when it comes to the knees. More to come on that, but probably where we'll head going forward.
Wonderful. Tricia, Dr. Ward, really, really appreciate the case study. And as a reminder, we will be sending out the recording and also the presentation for learning amongst the collaborative members. Just as we wrap up upcoming events, we will be having an additional webinar coming in the spring. And then we did want to let the group know that in August, we're going to be holding a bundled payment and care transformation summit. This is specifically around bundled payments, improving surgical care and optimization. This is going to be our eighth summit within the series that we will be sponsoring. And I'm going to just hand it over to Derek briefly to give a quick overview of what this is going to entail.
Right. Yeah, we're super excited to host the summit. Wanted to give a shout out to Bob Kaplan from Harvard Business School, who I see is on the webinar. Avant-garde Health grew out of work with Bob and Mike Porter, Harvard Business School. Bob will be speaking at the summit. We're honored to have him speak. And in addition, different faculty from Harvard Business School, it's really an opportunity to bring together everybody to hear different stories that Dr. Ward and Tricia shared today to help everybody be very successful going forward, not just in the team program, but more broadly with optimizing and improving all the different facets of their care delivery. We had over 180 people on the webinar today, and it's an opportunity to build and foster community amongst everybody and share best practices and connections. So we're excited to have everybody join us here in August in Boston.
Great. Thank you, Derek. Dr. Ward, Tricia, thank you once again. This was great. Really appreciate your time in presenting. Thank you to the rest of the group for attending. Be on the lookout for additional information in regards to the assets and the recording. And as always, if there's anything we can help with and be of service, please don't hesitate to reach out.